We will be doing this instruction course on scleral buckling, rediscovering scleral buckling. Scleral buckling, as you know, has been a gold standard for retinal detachment surgery. And it has, however, over the years, it has kind of lost its value, but we will be doing the rediscovery of scleral buckling over here. We are a bunch of young retina specialists, and we will be talking about how scleral buckling is actually still very relevant in today's practice, and how we can actually make it back in vogue. So we will have Dr. Sharath from Prasad Netralaya. He will be talking about the basics of scleral buckling. We will then move on to the finer aspects of it. We also have Divakant, Dr. Jayant with us, and we will be taking a deep dive into scleral buckling and how it is still a very relevant procedure and definitely essential for new retina surgeons and fellows to learn. Over to you, Sharath.
Thanks, Dr. Himadri. I thank Dr. Himadri and AS for giving this opportunity. So coming to the scleral buckle, I still remember when I joined my fellowship, and Dr. Himadri was my mentor. I can tell him as the first mentor when I joined him in the fellowship. And he was the person who is scleral buckle. And before that, when I was doing my post-graduation, I never cleaned scleral buckle. And what is this using pressing the eyeball, is putting some belt and all, I was thinking. Then as the day progresses, I felt this is the best technique which can be done in a retina surgery in that part of it. So I'll be talking about the scleral buckling, what is the conventional procedure part of it. So it is one of the time-tested extraocular surgical technique for the management of rhegmatogenous RD. It was initially pioneered by Arun Custodis, then Charles made it popularized. And now, even now in this vitrectomy era also, the scleral buckle is the gold standard. Once the retina is attached in scleral buckle is attached. So any core principles of any surgery in the retinal detachment surgery is to close the retinal breaks and to have a long lasting chorioretinal adhesions. So how the scleral buckle works? It mainly, to create a chorioretinal adhesion, we create a convex eyeball configuration. It reduces the anterior posterior traction and it supports the vitreous base. And when there is adhesion, it promotes the chorioretinal adhesion also. Coming to the basic principles, I'll directly jump into that. So whatever any surgery we are planning in the retina, the first and foremost is the fundus drawing. So we need to do meticulously fundus drawing, locate all the breaks, where is it, and draw it. So this preoperative and intraoperative examination is very important. And coming to the anesthesia, usually nowadays we do it in local anesthesia, peribulbar, and if the patient are not cooperative or in the younger patients, we also use general anesthesia. So what are the usual steps of traditional scleral buckling? So we do conjunctival peritomy, we isolate the rectus muscle, we do a cryo or laser to the break, we put a buckle, and then if sometimes we drain the fluid also. Let us go step by step for each this technique. So conjunctival peritomy, so we need to do a 360-degree conjunctival peritomy where we will be opening at a 3 and 9 o'clock position. So we leave a small frill of conjunctiva adjacent next to the limbus. And what we do, we go inside, we open the scissor and we cut around 360 degrees. Then we give a nick cut 3 and 9 o'clock position so that it will relaxed, and while closing it will be very easier. Next we do a tenons separation using a tenotomy scissors. We will go between the two muscles, we separate the tenons from that area, so tagging the muscles will become much comfortable. So make sure you separate the tenons very nicely, or else it can lead to the squint and all. So next to the rectus muscle tagging. So usually, as Dr. Himadri only taught me, we do inferior rectus first, then the medial and lateral rectus, then under the supervision, we do a superior rectus muscle tagging. And be sure while sweeping the muscle, sometimes you can entrap the oblique muscles, especially the superior oblique muscle, which can get entrapped. So once we take it out, make sure you remove the tenons every area and tie the sutures. And once you have tied the sutures, everything, inspect the sclera. Sometimes in a patient of high myopia or something, we can able to see there is a dark ectasia areas, thinning and all can be present. So then localize the breaks using end-eye ophthalmoscopy, and once you localize it, mark the break. If it is a large break, you make three point at the edges. If it is single, you can make a single break point. Do the treat the breaks, you can do it in various ways. You can do diathermy, cryo, or photocoagulation. Most of the times we use cryotherapy. So cryotherapy is a one which has started from long age old. We use nitrous oxide to make the cooling temperature up to minus 89 degrees. We use normally 2 to 2.5 millimeter diameter of probe. So this is the cryotherapy where you are seeing. So normally we, under the indirect we see we depress, and wherever it is located on the break, we try to do a laser. Make sure you are not doing heavy laser where it becomes ice crystals. Photocoagulation, you can use an indirect laser to photocoagulate around the break also. So next, suture placement is very important. Once you have marked it, depending on the size of the buckle which you are putting on. So if you are using a 276, it's better to put a suture and put it like as I'm showing you. Put the suture both anterior and posterior. Make sure you are not going very deep because the sclera will be slightly thinner. Usually we use 50 Prolin suture. And other technique what we do, if you are putting ensanclage band like 240 or 41, we do a scleral tunnel. Using a tunnel blade, we will do all the 4 quadrants scleral tunnel, which is much easier than putting the sutures. But yes, sutures will give you a nice indentation and amount of we can control with the help of sutures. So once we do a suture, we can put an ensanclage band around the areas. Make sure you go completely under the muzzle so that you are not later is not leading to any squint. Similarly, the buckle 276 buckle you can place under the buckle and then you can suture it. So buckle materials, as I told you, normally we use solid silicone nowadays. Depending on the amount of indentation required. Normally we go with the ensanclage of 240 degrees if you require only 4 mm. If you require more, we go for 276, 279 convex buckle. If 276 means it will give you 9 millimeter indentation. Similarly, 279 will give you 11 millimeter indentation. Depending on the breaks, we will select the buckle. So buckle positioning is also very important. We should make sure that is supporting all the edges of the retinal breaks and vitreoretinal degeneration. If it is slightly anterior or posterior, it can cause to fish mouthing. So when do you drain the fluid? Especially in the case of bullous detachment, chronic detachments, or in a poor retinal pigment epithelium function, then we try to drain the fluid. And draining the fluid, we can use multiple techniques. We can use a needle, just go posterior the buckle and drain the fluid, or else you can do a scleral cut down also. So nowadays I have stopped surf drainage a lot because we feel it can cause a lot of complication, and most of the cases can attach without doing a drainage, but yes, in the chronic detachments and all, better to drain. So then you see the pulsation of the central retinal artery. If it is no pulsation, you drain the fluid or do a paracentesis or just loosen the buckle what you have put. Post-operative management will give NSAID, oral steroids and cycloplegic medications. So what are the advantage over the PPV? So in young patients, the crystalline lens will be there, and therefore we are preserving the accommodation, and also doing a vitrectomy in young patient is very difficult because PVD won't be induced. So inducing a PVD will become difficult in those cases, and you may be creating extra breaks when you are doing in a young patient. And extensive lattice degeneration, you are supporting the ora and you are preventing the further breaks also. And as you are not entering intraocular, if you are not doing subretinal fluid drainage and all, there is a less chance of having endophthalmitis. But there are other complications like buccal infection, but endophthalmitis being rare. So complications I may not be touching now. So there are like a few complications which can happen like intraocular globe perforation and trauma. If it is not properly, it can cause fish mouth closure. There can be rectus muscle rupture, hyphema. Sometimes it can get failed. So that getting failed is mainly because not proper indentation of the buccal, or the patient is having a PVR changes. So I just skip these things. So the primary success of the scleral buckle and PPV is almost similar. Wherever is possible, try to do this. This is a gold standard surgery. Nowadays, many people are not doing this because PPV looks much easier doing the scleral buckle. But once you learn the art, this is much comfortable than doing the vitrectomy. So primary indication being a phakic detachment, dialysis, and young patient. Thank you.
Thank you, Sharat. Thank you, Sharat. It was a wonderful talk, and lovely to see you doing scleral buckle. We all learnt it together, and it was a wonderful time.
Thank you.
शरद, 1 second, just 1 second, हाँ. आ जाइए, इसमें दे दीजिए. Welcome to this presentation, but at the very beginning, I'd like to take a poll. What is your preferred technique for surgery in uncomplicated cases? So you just have to scan the QR code and you have to vote. Please, I request all the audience members to please participate in this. There are no correct answers, no wrong answers. It's just, what is your opinion? Wow, 100% pass planar vitrectomy. All right, that's a revelation. I will try to, change your mind over the course of this presentation. Okay, there are a couple of people who do prefer combined scleral. All right, great, great, great. So we will move on to my presentation, and through the course of this presentation, I'll try to show you that scleral buckling has a relevance till now, and probably I'll be able to change a few minds today. Right. So my presentation or my hypothesis, or rather my idea, is scleral buckling is still the best choice for all forms of primary retinal detachment, and we will see how. I do not have any financial interests. It was considered a gold standard for uncomplicated retinal detachment. However, there has been a growing shift towards pars plana vitrectomy. The preference for retinal detachment is now almost 80 to 90% pars plana vitrectomy, and very little, almost just 5% for scleral buckling for a primary procedure. So why has this decline happened? Availability of small gauge vitrectomy instruments has made it more exciting, more simple. There are economic and time factors as well. No industry support for scleral buckling, and certain misconceptions have creeped in. The success rate with scleral buckling is considered to be lower than pars plana vitrectomy, which is probably not true, and it is considered to have a high complication rate, higher rate of PVR. There has been no dearth of studies which show that scleral buckling is as good as pars plana vitrectomy, irrespective of the lens status, whether pseudophakic or aphakic. And when you combine a pneumatic gas or a air injection, the improvement of outcome is even more. A Cochrane review study published showed that there is hardly any change. It did a wide spectrum analysis and came to the conclusion that for simple rhegmatogenous retinal detachment, scleral buckling is as good as pars plana vitrectomy. So why is it now that scleral buckling is only considered for young phakic patient with no PVD? Dr. Sharath told us that why it is so, because scleral buckling is easier in these patients. Vitrectomy is difficult. When there is no PVD, you try to induce a PVD, you end up creating more breaks, you end up creating more problems. So scleral buckling is, like you say, slam dunk in these patients. But I would like to show that with this background, that it is not just in these no PVD cases. I believe scleral buckling can be done even beyond these few selective cases, and it is still very relevant. So coming to the study, we did a retrospective case study of almost 73 patients, 73 eyes of 71 patients, and we included phakic RDs without PVD, phakic RDs with PVD, pseudophakic RDs, aphakic RDs, and even complicated RDs. So I'll just be discussing the surgical procedure a little bit. This was a 72-year-old gentleman with a bullous retinal detachment. He was pseudophakic, and the initial steps, as Dr. Sharath described, we do a peritomy. Once the peritomy is done, the recti muscles are isolated. This, again, you have to displace the tenons, you have to do a fine dissection. Then comes the cryopexy and marking of the breaks. This cryopexy and marking is done under the indirect ophthalmoscope. We have to do the marking with a scleral marker. This helps us to identify the breaks at a later, when we are trying to put the buckle. This also helps us in proper visualization in the exterior, because once the breaks are well cryoed and once the marking is done, we can go ahead with the buckle. So as you can see, this violet mark, that is where the break was, and we use 5-0 ethibond sutures to suture the explant in place. We use solid explants nowadays. Ponds are not very preferred. There are two ways how you can do the 240 encirclage. You can make these scleral pockets, or you can also put sutures. I prefer the scleral pockets, but for beginners, even sutures do well. These scleral pockets are basically to keep the 240 band in place and do not have much use in how much indentation has to be done. The Wodsky sleeve is used to tighten the 360-degree, and then we go ahead with the fluid drainage, SRF drainage. So SRF drainage, as mentioned earlier, is now preferred only in very old RDs, bullous RDs, and in RDs which are more uncomplicated, we can actually just go ahead without a scleral buckle, without a SRF drainage. So again, we always get a question to how much should we shorten the band by. So for that, we have to go back to our school days where we learned that circumference is twice pi r. So we have to reduce the circumference to get an indentation. So if we have to have an indentation of around 1 millimeter, we have to have a new circumference, that is twice pi r minus 1. So that comes to around 6 millimeters. So irrespective of the size of the globe, if we want a 1 millimeter indentation, we have to reduce the circumference by 6 millimeter. So again, this is how it works. Twice, this is the old circumference, and for indentation of 2 millimeter, you need 12 millimeter of shortening. So again, 1 millimeter or 2 millimeter shortening is good enough for most cases, and depending on that, we can actually have a very good outcome. This was the patient who had a bullous RD and ended up with a good indentation, as you can see, and a visual outcome of 624. Now, we can do the same procedure even in aphakic patients. So this was a aphakic patient with a retinal detachment. Again, the initial steps being the same, cryopexy being very important. We use a double freeze thaw technique, and this mark actually tells us where the break is. We want to cover the entire break. So one of the things which happens is the cryo machine is not a very dependable machine. A lot of times we see that the cryo is not working. So what do you do when the cryo is not working? Do you just give up? So no, the cryo actually is not very essential immediately post surgery. If the buckle is in proper place, if the buckle has actually supported the break, then we can actually go ahead and just do the scleral buckle as it is. You can do a laser once the retina has settled. You can do a laser or a cryo after the surgery, because initial period only the buckle will support the break, and that itself will cause the retina to attach. So as you saw, even in aphakic patient, you can have a very good result. You can also do a SRF drainage in these cases. Again, another thing which helps us is if we add a pneumatic component to this, we can actually put in a air bubble. We try to put in one single bubble, which may not be successful at all times. Sometimes you can get multiple bubbles, but eventually I was able to get a single bubble. In case you are not doing SRF drainage and the globe is too tight, you can just do a core vitrectomy. So using a one single port, you do a core vitrectomy, and that will give you some space. Once you have created that space, you can go in and do a gas injection or a air injection. My preference is a single air bubble that actually helps to support the break, and within that time the retina tends to settle. Again, good results even in complicated cases with subretinal fibrosis, fixed folds, right? So these are multiple other cases. So now coming back to the audience. This is a break with a single break with a superior detachment. What would be your preferred technique in this particular case? Right, so what would you do in this particular case? Can you please vote? Wow, I have changed a lot of minds already. You will all go for, I haven't changed. Right, no, okay, we have a divided house, wow. A few pneumatic, a few vitrectomy, right, so we are getting somewhere. All right, so we also did a buckle along with the pneumatic. We were able to get away without SRF drainage. You can see the air bubble over there and the buckle indent. A month later, we had a very good outcome. This is the entire buckle, and the break, as you can see, has been supported by the buckle very well. Retina was attached, and the patient regained very good vision. Okay, another similar case, but here the patient has a retinoschisis as well. So you can see this break, and there is this area of retinoschisis. Again, coming back to the audience, what would be your preference in this particular case? Whether you'll go for scleral buckling, a pneumatic. All right, we'll wait for a couple of more votes. Right, so we have a 50-50 house, so some minds are changing. Great. So again, we did a scleral buckle with the pneumatic. Initially, as you can see, the brake had attached, but there was still some fluid in the subretinal space which had shifted inferiorly, although the retina was attached. So we just decided to observe. We did not need to do anything else. And a month later, the retina was completely attached. Patient recovered good vision, and the inferior subretinal fluid, which we had seen earlier, has also just absorbed. So this is one interesting case. This was a retinal dialysis, and as you can see, the brake was inferiorly. The dialysis was inferiorly, and there was a fixed folds very close to the fovea. So all right, going back to the audience, what would you do in a case like this? Fixed folds very close to the fovea, and a retinal dialysis. Would you go for a scleral buckle, or would you do a pars plana vitrectomy? Please. All right. All right. Buckle and a vitrectomy. Okay, that is also a good decision. Right. So let's see what we went ahead with. So I went ahead with just a scleral buckle. The retina settled very well. The brake was still open, but the retina had settled. And the fixed folds had started to open up by itself. No peeling, nothing necessary. I was not very happy. I did a barrage laser because the brake appeared to be very open, but the retina remained settled. The visual acuity kept on improving. The fixed folds, which was very close to the macula, completely opened up. And in spite of that, I added a little bit more laser, as you can see over here. So there is a very nice paper by Wong et al., which shows that even with open brakes, the intraocular currents change according to the Bernoulli's principle, and even in non-drainage cases, the retina tends to get attached. Right, so this is pushing the limits of scleral buckle. This was a very posterior brake, and we finally went ahead with scleral buckle, and the retina attached very well. Although the entire buckle could not support the entire brake, but still the retina remained attached, and I did not have to add any more add-on laser. So finally, coming back to the results, the mean age of patients ranged from 12 to 74 years, and the primary reattachment rate was very high, almost 95%. There was significant visual improvement, and only 4 patients required a repeat vitrectomy. So finally, even though it is considered less effective, it has a very high success rate. Easier to fix a scleral buckle failure than to fix a pars plana vitrectomy failure. But it does induce myopia. We have seen around -1 to -5 diopter myopia in patients after scleral buckle. There are advantages. Young patients, accommodation is preserved. In older patients, vitreous is preserved. And also, there is no need for a post-operative positioning. So to conclude, it offers early visual recovery after one single surgery. And I believe it should be the first choice in most retinal detachments. Thank you. So coming back to the final, okay. Right. So thank you very much. And we will now move on to our next speaker, Dr. Avanish. So Avanish sadly could not be here, so we will just be playing his presentation. Just hang on a second. I need an aux cable as well. Aux cable.
Usually they have macular involvements. They come with presentations of grade C or worse PVR changes. They may be bilateral in up to 30% of cases, and male preponderance is more. Once a patient comes with retinal detachments in pediatric age group, one should take a proper history of prematurity, previous infections, ocular infections, hereditary syndromes with systemic involvement, history of trauma. If a child is presenting with squint, nystagmus, hypotony, or cataract, there are very high chances the patient may have PVR. One should take previous history of any surgery done for trauma or any ocular syndromes. Pediatric retinal detachment can be of three types. One can be rhegmatogenous or could be tractional. Traction could be seen in ROPs, FEVR, and infections, and exudative RDs, which can be seen in Coats disease. Pediatric retinal detachment of the rhegmatogenous type is what I'm going to more talk about, and this presentation is based on. It constitutes around 5 to 8%. The patients may have history of trauma, the child may have history of myopia, previous intraocular surgeries, and presence of any congenital development anomalies. That sometimes the child may have sticklers where they have bilateral retinal detachments up to 51% of the times. So these childs may require other eye prophylactic barrage laser. The child may have marfans where there may be minimal displacement of lens, and bucklet could be done in these patients. One should be aware about thin sclera in these kids as can lead to scleromalacia, so doing buckling can again be very tricky. Why to do scleral buckle in pediatric age group? Because the vitreous is more formed and it is very difficult to induce a PVD and to remove the vitreous from the vitreous cavity. And second thing is the retinal brake tamponade is very effective once the traction has been relaxed by the buccal indent and support. That leads to very good anatomical success, and even we can get away with PVR cases. Even if you're planning buckle, one can do buckle with but doing vitrectomy alone is the least of the choices. So continuing further, vitreoretinal junction adhesiveness is or the separation of hyaloid is very difficult in these sort of patients, and the remaining hyaloid kind of splits and that contracts, further leading to PVR changes. Further on, you cannot separate the hyaloid more anterior to the anterior border of the brake, and that causes the vitreous to contract, and that can lead to redetachments. So these patients will eventually go into surgeries leading to retinectomies, lensectomies, multiple surgeries, and poor outcomes. So when to do a scleral buckle? When you have a very clear lens, the breaks are more anterior and there is less of PVR or absence of PVR. You can have once encircling circumferential buckles when there is no breaks identified or you cannot trace a break. You can have segmental or limited circumferential buckle, which we commonly use, and you can have radial buckles for single posterior HSTs. The principles of repair are release of traction from the retinal defect, reattachment of the neurosensory retina to the RP, and creation of RP with retinal adhesions with cryopexy. And do examine the other eye and do a prophylactic laser. The technique is 3 millimeter posterior and 2 millimeter lateral extensions of the buckle. The For anteriorly placed brakes, the buckle extends from the aura. For posterior ones, the anterior clearance of 3 millimeter is preferred. In case of vitreous vase with too much of traction, an encirclage of 2.5 millimeter using a 240 band silicon band is very effective in these cases. The width of the buckle should extend from the aura to the posterior edge of the retinal brake. The buckle should be broad with precise location of the retinal brake on the buckle to have a good successful surgical outcome. This video shows inferior subretinal fluid drainage using a 26 gauge needle. Once the fluid is drained nicely, the temporary sutures are fashioned. 240 silicon band, and in this case a segmental buckle 277 is used to tie it up in the infratemporal quadrant. Cryotherapy is done to the areas of retinal breaks and the area where drainage was done, and before closing, indirect is done to see the indent of the buckle over the area of break, and the surgery is closed. You can see this serial fundus photos where you can see there is subretinal fluid. The fluid is getting reduced, and you can see the areas of cryo marks, which later on present as scars. So conditions in which one can do scleral buckling with vitrectomies are usually infants or younger kids, and they can use a 40 number encircling band or a 240 silicon band. The bands are usually placed just anterior to the equator. Scleral belts are usually avoided in these conditions. Scleral buckling with vitrectomy is also done in ROP related detachments. The band is placed to support the ridge rather than to support the retinal tear, and sutures are imbricated to provide the height. Coming to a condition where scleral buckling can be done with chandelier, it's a good technique where the 25 or 27 gauge chandelier can be used. It is inserted 4 millimeters from the limbus, and it is usually placed at either diagonally or in the area of the detached retina for proper visualization. The advantages being it is performed under the microscope, so it doesn't require any wearing of any indirects or binocular microscope. Adjusting the focus and magnification will helping identifying undetected breaks. It can be used for surgical education and can be used in conditions with small pupil opaque media and smaller holes. So this is a video which we can see a chandelier is used, and under the microscope we can see that the cryotherapy is done, and with the help of the chandelier we can see the effect of cryotherapy taking place, and this can actually help in reducing the surgical time as well as good surgical results. So the disadvantages of chandeliers could be light toxicity in some cases, lens damage can happen, and infective end off can happen. So the ports of chandelier should be sutured, and this will prevent vitreous prolapse also, and maybe negating infective end offs. So post-operative complication of scleral buckling can be limited eye growth. So one should, if the child is less than 2 years of age, one should divide the encircling band approximately 3 months after the surgery, and later on the divided can later on that can be removed. The other thing which actually happens in these patients is amblyopia. So constant refractive rehabs should be done, and a pediatric ophthalmologist should be also consulted. Vitrectomy in pediatric patients are done in conditions where there is a poor fundus view, whether there is a cataract or a vitreous opacities are there. There is a total retinal detachment or extensive retinal detachment of more than 3 quadrants where buckling cannot be possible. There is extensive PVR, and the break can sometimes be very posterior. There is associated giant retinal tear, or in case some situations where no breaks can be identified, so vitrectomy could be the first choice of surgery. So to conclude, when you're seeing a patient with pediatric retinal detachment, a thorough history should be taken. A complete systemic and ocular examination should be done. The patient should be counseled for multiple surgeries and chances of amblyopia after surgery, and patient requiring more rehab. And as mentioned, early amblyopia therapy and prompt prescription of glasses and contact lenses will improve your surgical outcomes with good functional outcomes. Thank you.
Thank you, Avanish, for that wonderful presentation. We will be now moving on to Dr. Jayant. He will be talking about complicated detachments where actually scleral buckling can come to the rescue, and scleral buckling can be a wonderful, wonderful procedure even in those cases. Over to you, Dr. Jayant.
QAS for giving us this opportunity. So I'm here today to talk upon scleral buckling in complex retinal detachment. In the last talk itself, Dr. Himadri has shown many complex cases in which he has managed the case completely with scleral buckling. So I'd be proceeding with some case-based examples and few other topics. Let's start with some case-based examples. So let's look at this case. He was a 20-year-old young male phakic who presented with chronic retinal detachment, multiple subretinal bands right below the fovea, and cystic changes at the fovea. So if we go ahead with vitrectomy in this case, just imagine how are we going when we induce PVD, how is the fovea going to or the macula going to respond? How are we going to remove the subretinal bands? I simply went ahead with scleral buckling and just see the result in 15 days. Patient's macula was fovea got completely attached, the cystic changes were gone, and your subretinal bands actually did not cause much trouble. It was well settled retinal detachment, and the patient is doing well for 5 years in the follow-up period, maintaining 6 by 36 vision. Now we are in an era of vitrectomy where often things do not go as we expect. This is a case of macular hole surgery where I had multiple peripheral breaks, unexpected peripheral breaks. But the post-operative period was pretty fine. Patient had 6 by 9 vision, but at around 30 days of follow-up period, the patient developed inferior nasal retinal detachment with proliferative changes. There was pucker, and now it was a one-eyed case, and if I go ahead with a tamponade, I'll have to go and give silicone oil tamponade. Patient will have to maintain prone positioning. Patient is going to be quite upset with the series of events. What I did was simple 360-degree encerclage in this case, and patient had well settled detachment. The barrage laser marks which can be seen, that was done initially before the encerclage to ensure that the fluid does not progress from there, and patient had well attached retina. She's maintaining 6/9 vision now since last 1 year. The third case is a special case. I also got an opportunity to present that at ASRS this year. So it was a case of 18 years old girl where we can see how scleral buckling can help us. The patient had bilateral severe microphthalmos and nystagmus, and there was recent drop in vision in her right eye. And when we went ahead with clinical examination, vision in right eye was PL positive, PR accurate. Patient had retinal detachment with type 1 RC coloboma. Other eye had finger counting 4 meters vision. And retinal detachment was confirmed on ultrasound. So additional findings that patient's corneal diameter was mere 5 millimeters. She had developmental cataract. Keratometry was not possible. So if we see the challenges, the first challenge was that routine visualization systems were not possible for this case because you have a corneal diameter of 5 millimeters. Where are you going to place the ports, and how are you going to have any visualization system working for your case, because the size of all lenses, contact lenses, are much larger compared to the small eye. So even if we hear that vitrectomy is the solution for everything, for this case it's quite difficult. You have bulk of the globe which is filled with crystalline lens. So how are you going to go for ahead with vitrectomy? The machines are so bulky. So even if we go ahead with vitrectomy and have a lens touch, there's no option of IOL or SFI technically for this case. Aphakia will have no useful vision, band shaped keratopathy. So we went ahead with clinical reassessment for this case, and I could just realize one important clue that there was no posterior break in this case. And why not go ahead with a two-step plan? So what I did was, in first step, I planned to go only with 360-degree encerclage using 240 band, then go ahead with a reassessment, and then if required, like go ahead with two-port vitrectomy or endoscopic vitrectomy, whatever will be required that time. So with this plan, when I went ahead, I also realized that giving a peribulbar block in this small an eye will be very difficult. So you can see how tiny was the eye. So I went ahead with peribulbar block using 26 gauge needle. And then I could actually give a decent block, even though there was some nystagmus. Next important point, the instruments were very bulky for this case. If we go ahead with a simple muscle hook, so I went ahead and made a new instrument. I used a visco cannula, bent it at its tip, and placed it over a flute needle. So that became like a makeshift muscle hook. And now you can see that it was a very tiny eye. There was nystagmus. The instruments are looking so bulky. I go ahead with a visco cannula, modified muscle hook, mesh-shaped muscle hook, and then you can see that I could nicely separate the tenons and go ahead with hooking of the muscles. So next, another important thing was that now we had to pass encerclage. So this eye is going to have thin sclera. Its contour was very steep, so I had to make shallow pockets. I was very gentle, and time and again I was feeling probably I've taken the wrong case. Probably I should have just sent this case to a higher center. But then I persisted with my plan, and I could do a 240 band encerclage around this 5 millimeter cornea microphthalmic eye. So I also attempted like SRF drainage in this case, although not much of fluid came. And after giving ensuring that there was decent tightening of the band, I closed the case. and post-operative day 1 retina was flat. The patient had good buccal indent, and this case just proved that at times buckling can save us, and there was no need to go ahead for a second step for this case, and we could get success. You can see that this girl was able to count fingers with her right eye after 15 days. So another thing when we are dealing with complicated cases, that often we have failed scleral buckles, and an easy solution for them is rescue pneumatic retinopexy. So like, we need not go for vitrectomy in all of the cases. This particular report suggests 100% success in 22 eyes of failed scleral buckles, but still, I mean, I think it's an oversimplification. For inferior breaks, we still have to go for vitrectomy maybe, or buccal revision. And when to collaborate with vitrectomy, we can have cases like this where actually neither scleral buckle nor vitrectomy alone are going to be useful, and we can go ahead with collaboration between the two techniques, even do external SRF drainage, and you can see some of my own cases results. This was a very complicated case, doing very good after a combined surgery. The second case, almost closed funnel, improving to 612 vision. This is the third case, which could do very good. So to conclude, scleral buckling can be a better option than vitrectomy for selected complex retinal detachment cases. Rescue pneumatic retinopexy can obviate the need for vitrectomy in cases of failed scleral buckling, and collaboration with vitrectomy can act as a good hybrid technique for very complex and nearly closed funnel configurations of retinal detachment. Thank you so much for your patient listening.
Thanks a lot, Jayant. Thank you, Jayant, for that wonderful, wonderful case. So scleral buckle does work in a lot of cases. So we have Dr. Vaibhav's presentation over here. Dr. Vaibhav again couldn't make it, so he has sent a right. Could you please shift to this?
Visualization for the trainees and other paramedical staff during the surgery. The lack of skill transfer and crucial steps are mystery from the outside. On the other hand, vitrectomy has advanced a lot. Chandelier has all the advantages: good view, good skill transfer, effective training, and better ergonomics. जो दिखता है वही बिकता है. It gives a direct, non-inverted view of the retina while operating, and the zoom and focus option will make the surgeon's life much easier. Ergonomics is a key factor, as we are surgeons at a high risk of developing musculoskeletal disorders. Especially the neck and the back are an issue because we tend to do indirect ophthalmoscopy very frequently for all our patients in the outpatient department and in the operation room. Amongst a large cohort of vitreoretinal surgeons, 55% of them reported both back and neck pain, and 7% actually required surgery to relieve their symptoms. Chandelier-assisted scleral buckling also helps in virtual education, and as we know, e-learning is now the in thing. Our profession is a big pain in the back, so why add more pain? And with the advent of 3D retinal surgery, Chandelier here gives an edge to scleral buckling. So going through the key steps of Chandelier-assisted scleral buckle, we start with the conjunctival incisions are given as planned, and a proper tenon's dissection. Important stenotomy is done, and clear off the tenons around it, and make sure you don't injure the muscle fibers. Then you can go for either the horizontal recti, the medial or the lateral. Check and confirm complete muscle tagging, and make sure you don't impinge or get the obliques along with the recti. After clearing off, place in your chandelier ideally 180 degree away. Have a look at the break. Localize the break and do a nice cryopexy around the break. Chandelier here helps you. You can go in and come out. Externally localize your break. Make your scleral tunnels or scleral pockets the way you do it. And take your scleral suture. After 20D lens, make sure you unsterile or not. You just sit there ergonomically Do it properly. After the slip knots are placed, place your chandelier back into position. Here I normally use a twin chandelier because of my system, and make sure. So here there was a bolus configuration still, so I went ahead and did a 26 gauge needle prang method for subretinal fluid drainage. I drained out the fluid, gradually milking out the subretinal fluid contents, putting constant pressure from posterior coming to anterior.
All right, thank you, Dr. Vaibhav. I'll call upon now Dr. Divakant for his presentation. Why has it fallen out of vogue, and how can we actually inspire the new generation to get back to scleral buckle again?
Can I have the slides? So, thank you, Dr. Himadri, for inviting me. Always somebody who doesn't do that many buckles, but every time I go back from this IC, I expand the spectrum of my buckles. So I'll mostly be focusing on why it has fallen out of vogue, and the inspiring part has always been has already been taken care of. So I came across this thing. Lister in 1927 said that treatment of retinal detachment associated with holes should not be urged except in only eyes as a last clutch at a straw of hope. So this is what it used to be, the status of retinal surgeries back in 1927. But now we have moved on to a more advanced age where we are more, we have seen refined systems. It's the age of sutureless. All our surgeries are going to sutureless surgeries. I understand that from, as we've seen with the images as well, whenever we do a buckle, the eyes do not look that good on the post-operative day compared to a post-vitrectomy case. Our vitrectomy systems, from those ugly 20 gauge vitrectomy systems that I have not even operated upon, now we are steadily moving to more advanced systems. And as I said, the post-operatively at times, a lot of our vitrectomy patients, you can't even identify that the patient has been operated upon. So we always have the advantage of making a drainage retinotomy while doing a vitrectomy, and having a complete attachment at the conclusion of the surgery. So that gives a lot of satisfaction to the patient and to the doctor as well, to have a good attachment at the end of the surgery. We have the option, of course it's there with the barrage, the buckle as well, but we can do a good 360-degree barrage laser and secure our retina if needed in that case. I feel all of from the panel and the previous speakers are expert bucklers and do have probably very less surgical time, but on an average, if we would compare, vitrectomy would definitely have a lesser surgical time compared to these cases. Not just intraoperatively, I feel preoperatively as well, you need a very thorough examination. Again, being lazy should not be the cause of choosing this type of surgery that you do, but at times in a very busy clinical practice where you see a lot of patients, it might not be possible for a lot of us to do a very thorough preoperative evaluation. And as I discussed, a buckling surgery does give a lot of extensive tissue damage, and post-operatively the cases don't look that good. Again, the part with the preoperative evaluation, at times locating the breaks could be a challenge. Now, complications have been discussed partially, so I will not discuss, but again, indications where, buckle might not help, like multiple breaks in different quadrants, large or giant retinal tears, posterior retinal breaks. But again, all of these cases, our expert bucklers have demonstrated how they have performed surgeries in these cases as well, but it not be replicable to all of us surgeons who are not that good at buckling. Again, with media opacities, vitreous hemorrhage, additional procedures might be required, and buckle could not be will be difficult to do. You have tractional component, you have very extensive PVR, and a surgery has failed previously, and if you have an associated posterior segment pathology which needs to be tackled. So probably in all these cases we cannot perform a buckle. Thank you so much.
Thanks a lot, Dr. Divakant. It was a wonderful, wonderful session, and thank you, audience, for participating along with us. Uh, we definitely would love to know your opinion. So one final voting, please bear with me. Uh, screen dalna hai, screen dalna hai. Yeah. So will you now try scleral buckle more often after this presentation? Do you think it's possible, not possible? Just scan the QR code and you can put in your vote. Right, we'll just wait for a couple of more votes, yes. Okay, so we have some maybes, and majority of the house feels that they will try scleral buckle more often now. So thank you very much for this opportunity. Thank you, AIOS Scientific Committee, Dr. Namrata, for this wonderful opportunity. And I would love to see more people try scleral buckle more often, because it's a wonderful, wonderful procedure. As you saw, scleral buckle can tackle most cases. And for simple retinal cases, I believe it is definitely should be the first choice of surgery. Thank you very much.